Chairperson, learned audience. Good evening. I am Dr. Mohammad Arifur Rahman. Welcome you all to this session. My title is A Drowning Man Catches to a Straw. So my patient, Mr. X, 58 years old, hypertensive diabetes smoker, presented at dead of night with the compressive chest pain and dizziness for 2 hours. On admission, his pulse was 56 beats per minute and blood pressure was 80 by 50 millimeter mercury. An admission ECG showed is a very clear-cut picture of acute ST elevation MI inferior with sinus bradycardia, and also there is anterior leads T inversions. So it's a very clear picture that the patient has got an inferior MI and we should go for a meticulous management. Immediately, we give him the loading aspirin 300 milligram and ticagrelor 180 milligram, followed by normal saline and atropine to stabilize the patient. After that, we go for counseling of the attendance for primary PCI, and we have a vision that there should be some sort of RCA occlusion, and it will be 10 to 15 minutes to open the vessel. Ultimately, patient party was agreed. In the meantime, we got call from the attending physician that the patient has not recordable BP and pulse, and he developed asystole. Immediately, the CPR started. Patient was intubated as saturation also fall, and he was put on ventilator. Inotrope started along with normal saline to raise the blood pressure. So it continued at least 15 to 20 minutes. And then again we come to the patient attendants to describe the situation which is going on along with the few data. In hospital, CPR for cardiac arrest was associated with 40 to 50% success rate, but only 22% alive at the discharge. And if it is more than 10 minutes CPR, then prognosis is worse. Hearing the information, patient attendants are denied about the primary PCI. So what will be our next strategy? Then we discuss with the thrombolysis. Then we plan whether streptokinase or tenecteplase. After explaining both the situations, and they agreed to go for the tenecteplase, and we give the tenecteplase immediately. And it's a very soothing ECG after the tenecteplase that you see patient is on sinus rhythm, and there is also some sort of ST resolution. And we have a guess that there might be a very good recanalization of the vessel after tenecteplase. And as also a patient was hemodynamically stable on inotropes, then again we plan for a pharmacological strategy to see what's going on inside. After appropriate preparation and counseling with the patient attendants, we took the patient in the cath lab. But when we give the angiogrammic shot, we found there is a the L6 distal has got also a significant lesion, and LED was good. But RCA, the culprit vessel, after tenecteplase, the picture was not that much satisfactory, as because we have given tenecteplase, and you see there is total occlusion from the distal part, and also a significant lesion in the proximal part of the RCA. So the idea we got that patient has got a good recanalization after tenecteplase was totally wrong concept in this case. So we plan for revascularization. We took a 6-French catheter, run to floppy wire, and a balloon 2 to 15 minute rack, and we inflated at the 10 to 15 atmosphere. And we see the vessel was totally occluded, as maybe there was huge thrombus burden. Also thrombus may be also dislodged, occluding the distal segment of the RCA. So we put a 2.75 millimeter into 38 evaluation stent covering the distal segment, along with a 3 into 48 evaluation eluting stent covering the proximal segment. That there is a whole vessel was covered with stent. And the result was a bit satisfactory. Even then there was a slow flow. So we started integralin and also continued the integralin for next 18 hours. Patient was on inotropes and extubated after 1 day and discharged after 4 days. So if we analyze the course of the patient, the course of interventional procedure is totally unpredictable. Decision needed to be adjusted time to time or case to case base. Timely switching of the strategies may lead to a better outcome. Tenecteplase may not guarantee recanalization, so pharmacoinvestigative strategy is the reasonable option, and judicious use may end with a smiling outcome. Thank you. Thanks for patient hearing.